Aloha, everybody. We'll get started in 1 minute just to let people come into the meeting room, and we will get started in just a few minutes. In just a minute, there is a question and answer portion that should be on your lower part of your screen. You can enter any questions as they come up, and our guests today will be answering them at the end of their presentation. All right, let's go ahead and get started. Aloha, everybody. My name is Pedro Haro. I serve as the Executive Director of the American Lung Association in Hawaii. Now, I've spent decades advocating for lung health across our islands, but today I speak to you not only as a public health professional, but as someone whose family and entire hometown were forever changed by the August 2023 fires. I was raised in Lahaina. I went to King Kamehameha III Elementary School right next to the banyan tree in downtown Lahaina, then to Lahaina Intermediate, and I'm a proud graduate of Lahaina Luna High School. And like many of you, I watched in disbelief as the place that shaped me, its people, its stories, its soul, burned down to its very core. So this was not simply another crisis for us to respond to as professionals. This was personal. In my own immediate family, 6 homes were lost. That's only 6. That number doesn't begin to capture the devastation because hundreds of my friends and neighbors and relatives lost their homes as well. My sister and my nephew were among the many trapped on Front Street, surrounded by smoke and flames. And before I even knew if they had survived, I found myself on television talking about clean air and public health, trying to stay composed while my heart and my mind were somewhere else entirely. That's why the work you'll hear about today means so much to me personally. I can see the health impacts of the disaster on my own family up close, and I know that many of you can too. So to understand what has changed, we have to understand where we were. Across Hawaii, the American Lung Association's State of the Air report has showed that generally we had cleaner air than many regions across the country, with urban Honolulu ranking at the very top of the nation's cleanest for ozone and annual particle pollution, and the Lahaina and Kahului corridor being one of the cleanest airs anywhere. However, air monitoring gaps outside of the Honolulu metro area, including parts of Maui County, mean that some pollutants like ozone were marked as data not collected, which complicates assessing short-term risk associated with the localized spikes. Now, Hawaii has also maintained a lower than average adult smoking rate, about 10%, and correspondingly lower lung cancer incidence rates than the national average. But the State of Lung Cancer report reminds us that Hawaii still lags in early diagnosis and has gaps in treatment rates, meaning that the burden of disease is not evenly shared. Our state's COPD prevalence is among the lowest in the country, about 3 to 4%, representing roughly about 40,000 adults. Yet disparities exist among those with lower income or limited access to care, and particularly ethnic groups such as Native Hawaiians. These vulnerabilities tend to widen after major disasters. And at the same time, our youth have faced a growing e-cigarette challenge. In 2024 reports, Maui County's high school vaping rate was an estimated 18%, a serious concern because vaping increases airways reactivity and heightens respiratory risk during smoke events. So before the fires, we had relatively clean outdoor air, lower smoking rates and lung cancer incidence, a manageable but real COPD burden, and a significant youth vaping issue, and data gaps that limited our ability to fully measure the local air quality. That was our starting point. Now, let me take a minute to talk about what we mean when we talk about wildfire smoke. So wildfire smoke is a toxic mix of gases and fine particles that can penetrate deep into the lungs, exacerbating asthma, COPD, and cardiovascular disease, and carrying a special risk for children, kupuna, pregnant women, and those with chronic conditions. In the immediate aftermath, the Environmental Protection Agency and the Hawaii Department of Health conducted baseline air sampling and deployed real-time particulate matter sensors in Lahaina and upcountry Maui. Initial readings showed good air quality at the times measured, but with a critical point. Ash and dust can become airborne during cleanup, sifting, or high winds, posing serious exposure risk even when the ambient readings appear normal. This is why the N95 masks, the HEPA filtration, the clean room strategies remain so important for families who were returning into the impacted areas. Now, today's conversation centers around the Maui Wildfire Exposure Study, MauiWES, the most comprehensive health study ever conducted in Hawaii following a disaster, led by our presenters and their partners. And some of their findings are incredibly sobering. What they found is that 22% of tested adults showed reduced lung function within 6 to 14 months after the fires. Residents inside the burn zone had a 6 percentage point lower predicted forced respiratory volume compared to those outside. This is why we're very fortunate to have our two leaders whose work blends rigorous science with profound respect for community. Let me introduce you to them. Dr. Ruben Juarez is an HMSA Distinguished Professor of Health Economics at the University of Hawaii and co-leads the MauiWES initiative. He leads major initiatives along with the MauiWES, the U Hero Rapid Survey, and the Pacific Alliance Against COVID-19. His work brings data to decision-making, focusing on equity, trust, and deeply rooted in community. We also have Dr. Alika Manakea, who is a professor at JAPSOM, is an epigenomics. Did I say that? This is how smart he is. I can't even pronounce the things that he is an expert on. He is an expert in epigenomics and founder of the Epigenomics Core and co-leads the MauiWES initiatives. He's a native Hawaiian scientist from Waiʻi, and Dr. Manakea studies how gene-environment interactions shape chronic disease, and he leads work to uncover long-term impacts of biomarkers of wildfire exposure. Thank you so much for joining us today. I'll turn this over to you.
Great, mahalo, Pedro. Share screen. Let's see. Okay, let's start it here. All right, can you see the slides?
We can.
Great, mahalo nei. Okay, aloha mai kākou. Warm greetings from Hawaii. Mahalo for the kind invitation and introduction, Pedro, for us to be here today with you all in ELA. We are honored and really grateful for the chance to share our experiences following the Maui wildfires, as Pedro mentioned. While we are researchers indeed, we also present this work as members of a community that is still living through the aftermath, and hope that the lessons learned on Maui can help to build a better system that supports disaster recovery nationwide. Okay. Ruben.
Yeah, we have nothing to disclose. Next. So in August 2023, Maui experienced the worst natural disaster in the state's history and the deadliest wildfire in the US in more than a century. Lahaina and Kula sustained the highest exposure and structural damage. Thousands of structures were destroyed, neighborhoods were displaced, and critical infrastructure was lost almost overnight. But the most important point for this audience is not the scale of destruction, is that this disaster struck a place already shaped by housing scarcity, limited healthcare capacity, and deep social inequities. And that context, as you will see later in this presentation, shaped every health outcome that followed. And so to understand these health outcomes, we have to understand that baseline. Next. So it's important to understand what life looked before the fire. So Maui is a rural island with severe provider shortages and minimal behavioral health capacity. So for Lahaina residents, for instance, it can be roughly an hour to the nearest hospital. At the same time, housing is unusually constrained. 1 in 5 homes in Maui are short-term vacation rentals, limiting housing for local residents. Layer on all of this are extreme cost of living, especially for with large income gaps for service workers, renters, immigrant families, plus ongoing environmental and occupational risk with limited monitor infrastructure. So Maui is also a diverse multilingual community. So many households face barriers of aid because of trust, language, and documentation. So the fire didn't hit a blank slate. It actually hit a system that was already under strain. And that's why the central question for us become, how do we measure health impacts in a way that reflects reality on the ground? And that's what we're going to try to do in this presentation. So MauiWES works because it was built as an academic community partnership from day one. And we really appreciate the American Lung Association for being one of the strong supporters from the beginning. And honestly, we move at the speed of trust. So many of the communities most affected are the least likely to engage in traditional research and healthcare systems. So recruitment wasn't about advertisement. It was about showing up through these trusted community partners, which they are part of the community's advisory board in this case. And I can mention, at least a dozen of them who supported us. We also have a scientific advisory board that includes the U.S. Cancer Center, Mount Sinai, as well as several other institutions. And finally, we have our funders, that includes Kaiser Permanente, Hawaii Community Foundation, NIH State of Hawaii, and several other charitable supporters, so, which we really appreciate. Next. Most disaster health surveillance relies on administrative data, such as emergency visits, hospitalizations, insurance claims, but those data only capture people who can actually reach care. MauiWES was designed to capture health impacts before people reach a hospital, and in many cases, when they never do. So we integrate 3 components into the study that includes a detailed questionnaire on housing, employment, food insecurity, social support, trust, exposure. We also have biospecimens that include blood, urine, saliva, and allow us to measure stress response, inflammation, environmental toxicants, as well as we conduct an in-person health exam that include pulmonary health, cardiovascular health, metabolic health, mental health, screenings, and we connect people to services as needed. So this is how we try to make people who are potentially suffering from invisible harm measurable. This approach let us build a cohort that reflects the people most affected, not only the people who are able to access care. Next. And it's actually, a typical study that includes, a collection of biomedical samples as well as, a consultation at the end of the study with a physician as well as a mental health provider. Next. A core challenge of post-disaster research is representativeness. So the people most affected are often the hardest to reach. And one of the things that we are really happy is that the cohort that we have reflects not only people directly affected, but also people indirectly affected. And in these maps, you can see actually that although we oversample people from, in this case, the west side of Maui, which is predominantly Lahaina, as well as Kula, we also have participants from central Maui, and this is going to be really important in a second when we start looking at some of the impacts. So next. And this cohort, as I was mentioning, represents the diversity of the Maui population. People impacted by the fire includes Native Hawaiian, Pacific Islander communities that we know well in the state, the Filipino community that is about 20% of the Maui community, but it also represents a nascent community in Maui, the Latino population, that's about 11% for Maui, and potentially more if we count undocumented individuals. It also includes, mixed status households, renters, service workers, multi-generational families. This diversity didn't just happen by accident. It reflects recruitment through these trusted partners that I was mentioning at the beginning, and meeting people where they are linguistically, culturally, geographically. So scientifically, this matters, of course, because if you underrepresent vulnerable groups, you will underrepresent harm. Next. And just to give you an idea of some of the impacts, so more than 2,000 people joined MauiWES in the first year of the study. About 1,200 of them came back for a second year visit that we just closed last month. And starting this weekend, we are actually opening year 3. So people are going to start coming back for the third year appointment. So the goal, so we're actually asking for support to be able to reach up to 3,000 people in the upcoming year. So we appreciate anyone who can provide support to some of the bills that we have in place right now. And one of them is being heard tomorrow, actually. So happy to discuss more later. And I want to pause briefly here just to give you like a brief overview of some of the health impacts that happen 6 to 18 months after the fire. And if there is like one slide that you have to take, is that the disaster caused a variety of like physical as well as mental health issues. And so, for instance, about 46% of individuals reported worse health than before the fire. Mental health was also one of the big issues that we were able to find. So 1 in 5 participants reported PTSD, 1 in 2 were screened for depression, and 1 in 4 reported anxiety symptoms. Lung function, as I was mentioning, is about 1/4 of participants, with the steepest decline about among those participants in the burn zone, and Alika is going to be explaining this, as well as some toxic exposures with antimony, arsenic, at levels significantly higher than mainland populations. And this and other have been described actually in some of the papers. So this figure that I'm presenting right now shows one of the clearest patterns that we observe. So mental health impacts increase stepwise with degree of wildfire exposure. So in this case, we're able to separate individuals into 3 categories: those who are in the burn zone, basically Lahaina and Kula; those who are outside the burn zone, predominantly Wailuku, Kihei, as well as a comparison control that we have from outside Maui. And this figure is showing that mental health impacts increase stepwise with degree of wildfire exposure, from unexposed controls to people outside the burn zone who were indirectly affected to people inside the burn zone. And across depression and anxiety, the pattern is consistent. Each step closer to the fire corresponds to higher symptom burden. So this isn't just a binary exposure versus unexposed story. It's really a gradient of exposure. So the obvious next question is why? So what mechanism is generating this gradient of exposure? And that's one of the questions that we answered in our next slide and a paper that we have coming up next month. So again, so this is specifically for mental health. This gradient of exposure is actually driven by direct exposure to the fire, of course, but also by other aspects. And in this case, we're going to be disentangling this effect into housing stability, as well as housing displacement, as well as employment disruption. And what you see in this slide is that in the burn zone, more than half of the total effect of depression and anxiety is explained by housing and income disruption, not only direct exposure alone. The fire, so what this telling us, right, is that the fire is initiating that shock, but really displacement and income loss is sustaining this harm. And the same structure appears outside the burn zone, but at a lower magnitude. So reinforcing that this is not only about proximity to the fire, but it's really about instability. And Alika will now take you deeper into the physical and environmental exposure findings.
So following the wildfires, we assessed whether lung function showed measurable changes beyond symptoms. One of the more common symptoms that participants expressed in their self-reports when they came into the study and enrolled that day typically were things like respiratory issues, including shortness of breath, wheezing, coughing, etc. So using clinical spirometry, we focused on FEV1, which is measuring airflow, and FVC, which measures lung volume, and we compared results to national reference values adjusted for age, sex, body size, and smoking status. We found a high prevalence of abnormal lung function, which is also indicated here by the percentage below the lower limit of normal, especially of participants who resided within the burn zone, as Ruben mentioned, such as in Lahaina, indicating that the wildfire exposure might have caused clinically meaningful respiratory impairment. The lung function changes that we've observed were actually not uniform across Maui. Some regions had higher rates of reduced FEV1 and FEC, correlating with areas of more intense fire, smoke, and post-fire disruption, as Ruben indicated earlier. These geographic patterns suggest that local environmental exposures strongly influence respiratory outcomes, and you can see the distribution here on this map, again, measuring FEV1 and FVC on the bottom and the top and bottom slides here. We also found that wildfire release metals from burned homes, as Pedro mentioned earlier. It can also come from vehicles and infrastructure, and it releases into the ash and the smoke that can cause potentially toxic exposures. People can be exposed through inhalation, ingestion, or through dust. And indeed, elevated arsenic and other metals in the ash samples were reported by the Department of Health that prompted our biomonitoring to measure internal exposures using urine specimens that we collected as part of the study. So using high sensitivity mass spectrometry, we measured over 20 different elements in the urine samples from over 1,600 participants that were enrolled in the study so far, adults, including arsenic, lead, copper, and cobalt, to capture more real-world complex exposures. So surprisingly, metals varied sharply by region, as you can see here in Kihei and Wailuku versus Lahaina and Kula. The patterns and concentrations of heavy metals on average in individuals residing in those regions were very distinct. This indicated that the wildfire impacts were highly localized and, again, not uniform across Maui, similar to the patterns that we saw with lung health, which was more distinct than we actually had initially anticipated. Some of the metals could also be influenced by older legacy sources, which I'm not going to have time to go into detail today, such as the plantation era farming practices that's pervasive throughout the islands, and especially on Maui, though we're still investigating the exact contributions of these sources. Even more surprising and striking, participants from Lahaina clustered together based on their metal profiles. So again, these are the urinary metal profiles from the 22 plus elements that we surveyed from these participants. And you can see about 60 to 70% of these clusters were Lahaina residents in these blocked patterns here, revealing a really strong location-specific exposure signature. Now, this pattern was unexpected and highlights how wildfire exposures can actually create distinct chemical fingerprints tied to place, reflecting the unique intensity and aftermath of the fires. And this is taken from samples from participants that enrolled 6 to 18 months after the fire. So you can see some potentially lingering or potentially recurrent exposures that might remain. Another way to look at this data is by region, as I mentioned earlier, where you can again clearly see differences in individual level metal concentrations. With Lahaina participants, again on the west side of the island, showing a higher levels of wildfire-associated metals like arsenic, for example. These patterns persisted again after adjusting for individual covariates, highlighting that the sources of the exposures must be driven by environmental, not personal factors. And again, you can see how distinct these clusters are in these particular regions, the 4 major regions that we looked at, both Lahaina and Kula, 2 areas affected by the fires, compared to Kihei and Kahului and Wailuku, which we clustered together. Those are separated outside of the burn zones. We then looked at each metal individually to see if it might be, oh, sorry. Before I get to that slide, I wanted to make sure that we can also put this, the levels of heavy metal concentrations from the urine samples into perspective. So to put these findings into a context, we compared these metal levels to NHANES, the National Health and Nutrition Examination Survey, which measures health and exposure markers in a representative sample of the US population, albeit mainland population. Several metals in Maui participants were up to 2.5 times higher than the national averages, including in particular arsenic, for example, showing exposures well above the typical background levels and highlighting the significant impacts of the fires. We then looked at each metal individually to see if it was linked to lung function. Again, we saw this interesting pattern locally with metal concentrations as well as poor lung health that seem to be associated with regions. So we applied regression models that's shown here that several metals were associated with reduced airflow, or FEV1 again, and lung volume, FEC, and aligns with prior toxicological and epidemiologic evidence. The data shows a dose-dependent nature of metal concentrations. So in the graph on the bottom, you can see that there's increased levels of certain metals associated with worsening lung function. So again, arsenic, for example, you can see in panel A on the bottom, in the middle upper panel, in arsenic exposures, the higher levels of urinary arsenic correlates or corresponds to poor lung function, again, predicted FEC or FEV1 at the limits of lower than normal. Well, this suggests that even a single metal at a higher than normal level can affect respiratory health. However, people are usually exposed to multiple metals at the same time, especially after the fires. So single metal analysis don't necessarily capture the full complexity of these real-world exposures. So using a mixture model approach, we assessed how multiple metals together might impact lung function. These combined exposures showed stronger and more consistent associations with, again, reduced airflow and lung volume than the single metal model alone. So arsenic, for example, copper and cadmium in particular, remain the metals most strongly linked to impairment, accounting for up to 90% of the combined association to lung health. So altogether, these findings show that the wildfire exposure levels reveals a measurable, or leaves behind a measurable biological footprint, both in terms of the toxic metal exposures as well as the lung function loss. And that the health effects are shaped not just by individual metals, but by complex mixtures that can vary by community and geography. And I'm just going to note here that we are still collecting additional data, including exposures to other toxic chemicals, such as volatile organic compounds and pHs. Okay, so far we've seen a broad range of impacts that include mental health, lung function, and toxic exposures that persist months after the fires. These findings tell us that the wildfire is not a short-term environmental event, it's a long-term health shock. But this raises a deeper and more important question: who actually bears the greatest burden of this shock? What our data shows is that it's not determined by exposure alone, it's determined by pre-existing inequities. Housing displacement emerges as one of the strongest predictors of post-fire mental health, as Ruben mentioned. People who lost stable housing were substantially more likely to experience anxiety and depression, and much of that harm is mediated through housing instability and income loss. Income loss shows the same pattern, with large increases in anxiety and higher rates of depression. Poverty compounds everything, leading to higher psychological distress, worse physical health, and fewer pathways to recovery. Geography also matters. Lahaina and Kula are the closest to the burn zone and furthest from care, and they show that the highest levels of severe mental health burden on the island. So if we only focus on exposures alone, such as smokes, on the smoke, flames, or proximity, we miss half the story. The real disaster isn't just the fire, it's the inequity that determines who can recover and how they recover. So in response to the fires and to the data that we've collected, we've developed Ho'ala, which stands for the Health Outreach and Aina-Based Life Course Alliance, as Maui's first permanent rural prevention system. Rather than creating a short-term emergency program, Ho'ala is designed as a long-term community-embedded health infrastructure to serve Lahaina and upcountry families across the lifetime. We are integrating mobile clinics, telehealth, and point-of-care testing anchored in Lahaina and Wailuku. The model addresses the full spectrum of post-disaster health needs that includes lung health from smoke exposure, cardiometabolic disease and diabetes, cancer prevention, mental health, and toxic exposure testing, while building strong referral pathways for continuity of care. Ho'ala is not just a response to a disaster, it's an opportunity to build durable, prevention-centered infrastructure that supports Maui's health equity long after recovery. And we think this model can be expanded statewide as well as nationally.
Yeah, so,
Okay.
yep. So, and, I'm just gonna do it simple here, but I wanna add with a really simple idea that wildfires don't end when the flames are extinguished. They actually reorganize the conditions under which health is produced across generations, beginning with children. And what Maui is showing is that these health impacts are not driven by exposure alone. They are shaped by housing stability, income security, and access to care, and by the inequities that determine who can recover and who cannot. So in the future of disaster preparedness requires longitudinal community-embedded health surveillance, early integration of housing and income stabilization, as well as trust-based partnerships that reach those excluded from healthcare. So in that sense, preparedness is not just about the fire, it's about equity before the disaster, during the disaster, and long after the disaster. Thank you, and next. And thank you in particular to all the partners, community organizations, clinicians, funders, researchers who show up when Maui was needed the most, and especially heartfelt thanks to the American Lung Association of Hawaii, and especially to Pedro Haro. And literally MauiWES would not exist without the strong advocacy and support of Pedro. And we're especially grateful as well to the Hawaii Community Foundation, Kaiser Permanente, the State of Hawaii, and the NIH, who have been continuously supporting this work. So, mahalo.
Thank you so much for that. We do have a few questions, and if anybody has any questions, please go ahead and drop them into the chat, which should be open for everybody. And let me start with this because I found that super interesting at the end of your presentation. Can you talk a little bit more about what equity you're talking about before, during, and after a disaster? Expand on that, if you could, please.
Yeah, so one of the things that we are seeing, as I was mentioning at the beginning, is that access to care, housing stability, as well as income, are being determinants to be able to recover. And unfortunately, and as it was in one of the slides, right, the people who are suffering from health outcomes are those who, or are predominantly those who don't have stable housing, don't have a secure income, don't have as well as insurance access, things like that. So I think that one of the things that we need to emphasize is how can we build a system that allows to, when a disaster happens, able to quickly respond, of course, and cover these social bases that we know are going to be critical for the future recovery. So, and the second thing is, I gotta say that I'm very impressed by some partners who were able to help us, for instance, access to care for some of the immigrant populations in the state, right? Kaiser Permanente was able to provide this beautiful charitable insurance program. I mean, it's ending at the end of the year, but it allows basically individuals who are unable to access health insurance through traditional ways to be basically able to access health insurance. For many of them, this was the first time they ever were able to see a doctor in the U.S. So that was great program. We're able to see some of the impacts, but unfortunately, this was a small part of the people, who were able to access that program. So yeah, all of these programs are helping, and we're hoping that as we continue evaluating this data, and we just finished collecting the second year data, we're going to be able to continue this untangled, what are the social aspects that are able to determine recovery moving forward. So,
and speaking of all of this, because what you folks are doing is community participatory research, right?
Yeah.
Can you talk a little bit more about that, of how your study is structured to be community first, and also how have the people of Maui that have been affected by the fires helped shape the research?
It's a great question. So we started actually with our community partners on the ground to design the study in the first place. Actually, my uncle and I visited Maui on an invitation to come to help out with the hubs at the time when the disaster was the recovery was rolling out very immediately, just to meet the urgent needs of those that were affected by the fires. And so we sat down with them, talked about what kinds of experiences that they had concerns around, needs that they felt that was important, and co-designed a study, including them on our community advisory board from the start. And so we operated with the sense of not only collecting data that we needed to understand the problem, but also to provide some support and relief to the disaster, and including the health screenings that we incorporated. So lung health as well as mental health were some of the screening tools that we brought in place were actually something that the community advisory board strongly suggested that would be an urgent need, because they saw that was a critical a gap in the recovery process that needed to be filled. And so we decided, with the intent of not only collecting data, but to provide those services, and also to link people to services like Ruben mentioned, that didn't have that potential, that insurance coverage or healthcare provider, for example. And we tried to link them as best as we could to those services based off of their individual needs when they came in through the study, and get their health assessment. And to kind of give you an idea, this was done really as close as possible to the fires as we could, 6 to 18 months out, right? When we opened the study and started to enroll. And despite the fact that people came and joined the study with symptoms, and also and even some of them who had insurance and who had providers, this was their first health screening of any kind after the disaster. So that was kind of surprising to us. About 60% of participants that told us that. So then the idea was that not only were we collecting information from the participants enrolled and samples to understand the toxic exposures and other things, but wrapping that into the study to include these health services that were needed at the time, and especially provided and still needed, presents a big challenge for us to continue going forward. But the idea is that it really was led by the community in terms of what kinds of needs that we would address as we are collecting information. And then all of the data as well, in the reports that we release and in the sharing of information that goes back out to the individuals in the community, are also shared at the community level. So I think that's been one of our major goals since day one, is making sure that this was a community-led initiative.
Mm-hmm. Ruben, and you in particular, you have a skill set that was brought in. We know that Lahaina in particular had a disproportionately high amount of Hispanic immigrants. Can you tell us about, what was the importance of making sure that they were captured fully, and what you folks have been doing to be able to accomplish that?
Yeah, so that is actually a great question, and I think that the Hispanic. So one of the things that Latinos and Hispanics are basically are well known in the U.S. There is high representation of Hispanics, right? But I think that the Lahaina fire was able to show us that there is a systemic issue in the state, especially with policymakers who didn't even know that Hispanics are in Hawaii and represent a significant proportion of the population in the state. It's 11% of the population. So when the fire happened, I'm actually treasurer of the Hispanic Chamber of Commerce. We started receiving calls from some of the first responders asking us, why is there like a need for Spanish language services, right, in Hawaii? Like this is not something that they were expecting, and luckily we were able to like support some of those needs. But that actually made us realize that an immigrant population, okay, that Hispanics blend really well in the state, right, was unseen. And for that, community organizations were formed actually to literally on the day of the fires to be able to address this, like Roots Reborn. I mean, and it's one of these organizations that was formed, I mean, to be able to take care of immigrant population that was being underserved. And yeah, so I think the thing that we are seeing is that these individuals, again, were unseen. They didn't have access to care. We knew that it was extremely important for them to be able to build trust, in the systems that exist. And so we brought MauiWES, and right now, until today, we continue on a regular basis engaging them in different ways. One, obviously, through community partnerships. That's an important way, but also by having Spanish speakers, by having people from the community at the events who are basically supporting. And I'm really proud to say that participant number 1 of the study is actually a supporter, right? She had been there, cooking for us every week that we're in Maui, and contacted participants, just to bring them into the study. So yeah. So I think that we're happy that the way that we are recruiting the Latino population, as well as other immigrant populations, right?
Yeah, and thank you for that. And Alika, you've been working on, on chronic disease and Native Hawaiians for a long time. Lahaina, West Maui also has a high population of Native Hawaiians. And what we know from our data is that Native Hawaiians typically have worse outcomes, health outcomes with, across the spectrum of chronic disease, whether it's COPD or diabetes or any of those aspects. So what are your long-term concerns about, particularly for the Native Hawaiian population?
Mahalo, Pedro. That's actually part of the reason we decided to really implement this initiative early on, is really in response to what my great-grandmother would do. She was born and raised in Kula and partly raised me in Nanakuli. And she was a healer herself, and really focused on sharing the message that Aina is healing, and really connecting back to Aina-based practices is part of our heritage. And I think the whole understanding of how environment shapes our health is really linked in that, cultural ike, our ike kupuna, cultural knowledge. So you mentioned, yes, we do have a high rates in the Native Hawaiian population of certain chronic conditions, including diabetes, heart disease, even certain types of lung cancers, unfortunately. But not only do we see a higher prevalence of those chronic conditions, but we see it appearing earlier at a younger age in our population compared to others. And we're still trying to understand the reasons why. And I think there's a combination of these social trauma that we experience, but also cultural trauma that sort of we inherited from our colonization, right? So I think that's a much more deeper sort of rooted vulnerabilities to these chronic conditions that we're still recovering from. And I think that's partly why we see these higher rates. But that said, though, I think, again, going back to Ike Kupuna, Aina can be healing. And so we've learned from other community partners and other studies where nutrition programs, educational programs, linking to identity, as well as leadership building, capacity building in the community really strengthens community ties, as well as improves overall wellness and physical health. We've seen that in studies where we work on with Mount Organic Farms, for example, in Waianae, and we see it in other places on the Big Island, cultural-based practices really improving health. So using our Ike Kupuna, really tying it back into these practices that we know we benefit from and expand on as helping to prevent these chronic conditions is something that we're working towards statewide. So while we do see these disparities, I think we can use our cultural knowledge and practices that can actually help our community to not only recover from disasters like we saw in Lahaina and Kula, but to strengthen our resilience to those disasters by enabling prevention. And so that's something that we're expanding on, not only within our Native Hawaiian population, but has of course implications more broadly across the state. And so our challenge right now is to be able to create that infrastructure so that we can have these shared co-learning spaces with our community. And that's part of the Ho'ala model, is to bring that capacity in with not only education and health services and screenings, but also the research capacity, and incorporate indigenous knowledge where we can, so that we can improve the health and well-being of our community, knowing that the environment plays a major role in shaping our health. And I'm not talking about just a physical environment like the toxic exposures that we're saying, but also the social and built environment around us, which makes a big impact. So I think as we think about sort of the future of reducing or eliminating health disparities across the board, building in these programs are going to be really important moving forward to enable prevention. And that's, I think, how we can change the dial. So although our study focuses right now on sort of the recovery stage from the fires, I think there's a lot more systemic issues that we are starting to address that incorporate this. How do you understand how environment really shapes our health, and what then can we incorporate in terms of our daily lives and to reduce risk and mitigate disease conditions, right, and burden in our communities. So that's something that I think that the research can help elucidate, but also, again, leveraging our ike kupuna and our indigenous knowledge systems already that we have in Hawaii, which makes us unique, but also offers an advantage for us because this is our place, right, here. And so, and we knew that early on too into the disaster, that how the remoteness of being in Hawaii is going to make it even more challenging in the recovery process. And we saw that play out in terms of the differences that we saw in our experiences here in Hawaii, comparing it to what California is experiencing right now in their recovery after the year one now of the fires on that side.
So can you folks expand on that? And I don't know, Ruben, if you want to step in, but the larger implications as to essentially what to do after a fire, right? And so how do we build those systems that are more robust, that are encompassing? What are those lessons that we're learning even at this point?
Yeah, so I think that's a great question. Equity is not a slogan, it's actually an infrastructure, okay? So before disaster, equity means investing in communities that are already facing provider shortages like Lahaina, Maui in general, housing stability, language barriers, right? Environmental risks. It means building trust before you need it. I mean, this is really important and something that I want to emphasize, right? Because having these partnerships with community, establishing community-embedded surveillance systems that use our community-based organizations is extremely important and a critical thing that Alicana have been trying to build for many years, right? But now we're trying to launch it with Ho'ala. And then it really means strengthening respiratory health infrastructure, spirometry access, environmental monitoring, school-based screenings before smoke ever fills the air, right? During the disaster, of course, we want to make sure that we have a response system that do not depend on income, insurance, immigration status, geography. Again, really important, right? And so grateful, to Kaiser for coming up and with this charitable insurance program. But it really also means rapid access to clean air shelters, mobile lung testing, medical continuity, multilingual communication, housing stabilization. And finally, after the disaster happens, equity means staying there. It means building these longitudinal follow-ups, like what has been built in other disasters, but has not been built in Hawaii. And you know, the clinics at the 9/11 centers are a beautiful example of like what they were able to build, you know, with strong advocacy at the national level. And I'm really hoping that we are able to build in Hawaii, because these long-term health consequences are going to stay there for a long time. And we need to be able to monitor and link people to care. So, and I'm not only talking about physical health consequences. So we know that more people died in 9/11 after exposure to environmental disasters than during the disaster itself. But if we don't act right now, I mean, we can be at this position. But also, you know, beyond the physical impacts, we also want to make sure that we build the mental health capacity, mental health services, you know, housing recovery integrated with health and ongoing pulmonary monitoring and toxicology surveillance systems. So that's how we see basically how to build a resilient system.
And
anything
you know
to add,
that.
Alika? Oh, sorry.
No, I think you covered it. I think the idea is not just a one-time sort of assessment, but longitudinal assessment is really important to kind of give us a better idea of what's really happening. And monitoring it even before the disaster is really important. And I think that's something that you know, we can learn other areas, especially vulnerable areas, and in areas with deep inequities, could really learn from, is trying to incorporate these types of infrastructures that can help monitor sort of the steady state of the situation on the ground, and provide the supports that they can to alleviate the strain of those inequities while they're trying to collect that information and trying to improve and optimize sort of the best practices so that they can really change the dial on these health complications that emerge later on. So I think, going back again, it's really about trying to enable prevention where we can, and learning about some of the community context that the recovery is playing out is really important.
One of the things that makes your studies very interesting and so strong is that you have access to other data sets because you have conducted multi-ethnic cohort studies in other groups. Can you talk about that, about having the ability to have that control group, to be able to compare to groups outside of those affected by the fires?
Yeah, so I can talk a little bit about that, but and this is actually on a paper that's coming up on March 11. But yeah, basically during another disaster, during COVID, actually, we realized that we just didn't have the infrastructure to be able to rapidly provide data that is usable to decision makers as well as to community, right? And you know, with the help of the state of Hawaii at the time, as well as Hawaii Community Foundation, we're able to build this longitudinal data set of 2,000 people across Hawaii that allows to provide data that is important to be able to like disentangle some of the social determinants as well as health outcomes as a result of the social determinants, but really have a baseline and be ready for the next disaster. So when Maui hit, the first thing that we knew is that, okay, we already have this cohort that we're able to like compare the Maui population to be able to look at some of these impacts. And so yeah, so we've been ready, you know, for the last 5 years with this UHERO rapid survey, which just waiting basically for the disaster to happen to be able to provide this actionable data. And we're able to see, for instance, that, you know, prevalence of depression on the state is about 30%, about the same for the Maui population, pre-wildfire. But once the wildfire hit, this went up to 50% for people affected by the fire. So almost double basically the prevalence. So these are the type of things that are really important for us to be able to measure the impact of the disaster, and as well as being able to disentangle, you know, what are potential effects. And and not only measure, but like really provide these interventions that are effective. So you hear rapid survey is one of them. We have another one, which is a large cohort of diabetes that Alika can talk about, as well as obviously, I mean, there is this larger data sets that exist in the state. I mean, the US Cancer Center, as well as others. Yeah, predominantly that you hear rapid survey is the one that we've been using.
Right. Well, let's stick with that mental health topic. So your team found that strong social support networks significantly reduce depressive symptoms, even among people who with high wildfire exposure. Can you talk about what the Maui community is doing to sort of build, or how we can be building strengthening those networks?
Yeah, a couple examples come to mind. I mean, Ruben can maybe fill in some of the gaps there, but so we knew already before the fires happened on Maui that mental health was a pretty pervasive issue throughout the state. I think the UHERO data that Ruben mentioned, that baseline cohort that we had enrolled participants in, and using the same sort of tools to assess self-reported mental health symptoms, found that about 30%, I think, overall of those participants expressed some degree, either severe or mild depression. So that was kind of already an alarming statistic to learn. And then, of course, knowing what happened on Maui, that was just exacerbated. More than 50% then of that population affected exhibited symptoms of depression. So I think just learning about the reality on the ground, even before the fires, like what are contributors to that? One of course, was the gap in the services, the mental health services that was lacking, especially in rural communities like on parts of Maui. And also the capacity in the workforce, right, in the healthcare workforce that also shapes the types of access that we would get, and delays in the care and the coverage and all of that, of course, with access issues. So that we found that early on that was a big problem, and of course trying to increase that capacity in a short time frame in response to the increased need is a huge challenge for anyone, right? It's not just limited to what we saw in Maui. Even on Oahu, that would have been a big challenge. The problem is, I think, is that some of our pockets, especially with our culturally diverse population, some of the types of modalities of mental health and behavioral health modalities may not be so compatible with addressing some of those issues in those populations, and especially with the language barriers, but also certain sort of cultural contexts and sensitivities around talk therapy, for example, and other things. So, and then reaching, of course, different age groups, because it's harder to reach kids versus adults, for example, for that. And we've had experience working with our mental health providers directly in terms of providing some of that services and support. And so learning from them as part of the study was really insightful to figure out how we can best address some of these gaps. And what we've learned is that we maybe need to think outside the box and actually learn from, again, drawing from Ikekupuna, looking at some of the traditional practices that were done to address some of these issues, such as just these cultural activities. In particular, one of the examples I can share was related to an organization that's doing a lot of water sports with youth on Maui, such as canoeing and surfing and all of that, and making sure that there's a place for those, especially those that are affected by the fires, right, to continue that kind of activity, because it provides that social support and a potential way to address some of the mental health issues around the trauma that's experienced, in a way that might connect better to these individuals in a cultural and community context that may not be necessarily seen in sort of the traditional sort of talk therapy mental health kind of approaches, right? So leveraging that, we are actually working with a partner there that's using the same tools in terms of the screenings for mental health to see if that type of approach actually is effective in providing that kind of support. And so again, working with community partners to see how effective these types of alternative approaches to address some of these issues are, and incorporating that as part of the practice, right? And building the infrastructure for prevention in these communities that are culturally diverse, but also and distinct, but also really remote and and rural in a lot of ways with limited access to care. So maybe that could be one of the ways we can cover that gap, instead of the sort of the more traditional sort of route of training more professionals in those spaces and trying to incentivize people to get into those spaces so that we can increase the capacity for the healthcare providers. But like I said, there could be these alternative practices already in place that's potentially more effective, less expensive potentially, but also connected to other things that affect wellness in general in the community that could actually play a role in providing that kind of support. So tapping into that, and that's why we called Ho'ala as part of the alliance, is really part of the practice, and trying to understand how we can incorporate that as to help elevate the infrastructure for health and well-being in our community. And so I think that's something where we're really looking forward to demonstrating statewide, whereas of course there's an immediate need on Maui to kind of target it initially and expand on it, because there's that emerging need. And kind of just as a side, although our population, we do cover children, about 200 more than 200 children are enrolled in the study. But most of them are adults. We'd like to increase that capacity so they can get a better picture of what's happening, on Maui. But also, we have the Maui Health Registry to capture those that are not officially in the study but want information on how what we're finding, as well as some of the resources and the networks that we're uncovering that could help benefit those survivors that may not be part of our study, so that it can so the work can get out there to those that are remaining on Maui, but also to those that might have been displaced and relocated. So we're hoping that the types of the data, as well as the linkages to these community-based practices and these organizations that are playing a role in recovery, can help reach out to those individuals as well. So not necessarily those that are within our scope and within the study itself. So it can really affect the broader community.
Yeah, and one of the things that, as Alika was mentioning, right, strong social support is associated with depressive symptoms. It's actually 50%, 1 in 5. Sorry, 1 in 2 participants affected in our cohort, right, that have depressive symptoms. So the practical question really becomes like, how do we intentionally strengthen those social networks, right, that we know are associated with. Yeah, we've been doing it in concrete ways, and the Maui community has been doing it in very intentional ways. And I'm really happy about some of the programs that have been created. Right, of course, it's not enough. It's never enough for the need, but there exists some. So the MauiWES events, basically, that we have, and the partnership with the Lahaina Comprehensive Health Center has been really critical for us to be able to not only measure, depression, anxiety, suicidal ideation, and some of the physical health metrics, but also some who experience positive, we actually directly connect them to care. So Dr. Knightsbridge, who is not here today, is our mental health lead, and as well as local providers, have been taking on participants that screen high for depression, right? And as soon as they come to the screening events, we connect them. Especially in West Maui, where behavioral health capacity is pretty limited, I should say. The second, we know that Lahaina had severe provider shortages even before the fire. So part of the response has been embedding screening into trusted community sites, not just waiting for people to come, right? Because just because you have a center like the Lahaina Comprehensive Health Center, right? I mean, people are not just going to come when there is a need. So I think being able to bring people in through different ways has been critical, and partnership with community organizations has been really critical on this. Community centers, mobile events, potentially expanding into schools. That's our next goal for the upcoming year. And yeah, so as Alika was mentioning, reinforcing culturally grounded programs, AINA-based activities, community gatherings, multilingual support. These are not add-ons, you know. I think for Native Hawaiian, Filipino, Latino families, culturally anchor spaces restore, a way to connect for them to and fill these gaps that are needed. So overall, we're trying to move beyond one-time service toward more sustained, integrated mental health infrastructure connected to the Lahaina Comprehensive Health Centers, but as well as to schools, as well as community-based organizations.
Thank you for that. And just as a reminder to everybody that's here, you can enter a question in the chat, or you can also just send it to me, which some of you have been sending private messages to me. So I'll go ahead and ask some of those questions now. People want to know how you're funded and if you're struggling with funding.
Well, yes. So we are funded by the National Institute of Health, who is providing basically about 1/6 of what we typically need. And this funding is ending on June 30th, unless renewed. So we don't know if we're going to be renewed or not. Then the state of Hawaii has been really grateful, obviously, on providing some of the big chunk of the initial money that we needed to be able to expand the study. But really, the two main funders that initially came was Hawaii Community Foundation and Kaiser Permanente, who were able to provide some of the bulk of the funding initially to be able to launch a study, and now to be able to continue it for a second year. But yeah, so unfortunately, I mean, to be able to sustain it and expand it, we're trying to build this infrastructure that requires state support as well as federal partners. So we're hoping that we have a couple of deal appropriations to continue funding MauiWES until the end of the year, as well as to expand it for next year. So if you guys can support those bills, we'll appreciate it. One of them is being heard tomorrow. And I'm going to put on the chat actually the bill numbers that are going to be heard. And then yeah, so and honestly, I think that we are trying. I mean, we're struggling. Okay, so to be able to sustain the study, but luckily, every time that we are close to closing the study, a funder is able to allow us to continue with this gap funding. But yeah, anything that people can do to support the study, we'll appreciate it, of course.
Thank you for that. Here's another question. I'm not sure if this might be something that you might be able to answer, but how might childhood exposure to wildfire smoke shape risks for things like diabetes, inflammation, and other disparity-related conditions you study?
Yeah, that's a great question. That's something that we're starting to trying to understand, especially with the cohort in children that we were able to recruit, thankfully, actually through our community partners, because they really wanted to be able to cover that, knowing that children are vulnerable to those types of exposures. One of the things that we're concerned about, especially relevant to the ALA, is the lung health trajectory. So the lungs still developing in a sense in children, and actually in the capacity in which we can breathe, the air volume and the elasticity is somewhat dynamic over the course of your sort of adolescent to adult transition. And typically, I think up to mid-20s, there's some aspects of that development being developed, still playing out. And so the idea is that potentially these exposures to these early stages of development might reduce healthy development in the future, and that could increase the risk for future cardiovascular events and other chronic conditions. And there's a number of studies that have been showing that. We don't really understand that trajectory in our population very well locally, and especially compounded with some of the, although we do have generally good air quality, there's occasionally the fog that comes through, and that can cause problems. And we do see some associations with increased prevalence of asthma in certain regions, and especially in childhood asthma. So potentially those exposures beyond just the fires can contribute to these higher prevalence of the chronic conditions that we see already. So that we're still trying to understand how that plays out, but definitely what we're trying to understand in particular, the mechanisms, how that works, is that we think that some of the inhaled toxicants, like I said, the heavy metals that could reside in your body for a period, especially in the lungs, can contribute to local inflammation. And then that can perturb sort of the growth trajectory, especially that early age during development, that at a certain point, when you reach that sort of max capacity, that can actually shape your future health risks for chronic conditions. So we first need to map that trajectory out in a healthy population. We just don't have a good numbers to do that in our current study. So that's why one of the things that we're trying to do is increase that capacity to enroll more participants, especially children, to look at that. And the others, of course, is the concern about that exposure. How is that exposure related to that trajectory? And so that's something that we can only do in studying it longitudinally. And so that's why the funding is really important, so that we can continue this assessment. We already have a pretty strong baseline recruitment with some really robust data elements behind it. So then the idea is then we're now going to the third year of follow-up. And so looking at that trajectory play out is going to be really important to understand how that associates with future risk and how we can actually intervene early. Because the idea really behind all of this is trying to identify key indicators, whether it's social factors, environmental factors, biological factors, that could actually help us do a better job in predicting risk outcomes to specific outcomes like cardiovascular disease and cancer events and other things, so that we can enable earlier detection before those clinical manifestations, and then help participants enroll in interventions that could help reduce that risk, right? Through more these preventative modalities that I mentioned earlier. So tying that back in, I think is really the idea about Ho'ala is being able to conduct those assessments longitudinally, so that we can better learn how those early exposures and associated risk factors might then contribute to individual level risk for development of these particular outcomes that we can hope to, improve by incorporating this information into sort of the health and wellness landscape throughout the state, so that we can enable prevention.
Thank you for that. And there's a question about what can people do. I just want to point out that Ruben put into the chat the two bills that are actively moving through the legislature this year. Certainly any testimony in support for the funding of this program would be helpful. So please go ahead and take a look at those links, provide testimony if you're able to, particularly if you have been affected by the fires. Certainly, if you're a public health professional and understand the importance of longitudinal study and long-term funding, that's another perspective to take. Or if you're just a concerned community citizen, because one of the things that we have to think about is that, this doesn't just affect Lahaina, this doesn't just affect upcountry Maui. This is the future possible impacts of the fires can be far-reaching, including to those of us who live, on Oahu, in Honolulu. When we're talking about shortage of doctors, when we're talking about expensive procedures or length of time that it takes to get to see a specialist, all of this, it will be exacerbated if we're not able to meet the need of the folks. So it's, as much as we want to think about it as we're helping Lahaina or we're helping Maui, we're actually helping our entire healthcare system by making sure that we're tracking disease and we're responding to it before it becomes an emergency. There's another question that came in, which I think is super interesting. It says, if you had to pick one urgent health investment Maui should make now, what would it be?
Man, that's a tough question. I don't know if there's any one single thing, but I guess more broadly focusing on prevention, and that has a lot of implications on what that would look like. But I think tapping into low-hanging fruit for me, from my perspective anyway, is tapping into our community organizations that are already on the ground working with vulnerable populations to address different needs, right? And it could be educational needs, health needs, as well as sort of social needs, mental health, all those things. But they all play a role in shaping sort of the health and wellness around our population. Strengthening those connections between those organizations in a way that is intentional to shape prevention, to help address that, is going to be really, I think that's for me, the low-hanging fruit to tap into. It's already there. It's just bringing it together to make it part of the standard of care that we provide in our community, is going to build our resilience to disasters like this.
Yeah, and so pretty similar to that answer. I mean, I think we need to figure out how to build a permanent community-embedded mental health capacity in West Maui that fully integrates with primary as well as respiratory care. So the wildfire didn't create just smoke exposure, of course. It really destabilized housing, income, social networks, all of that we know contribute towards depression, anxiety, stress. So pre-wildfire, Lahaina already had severe behavioral shortages. So I think addressing that it's really important as we move forward. And honestly, ensure, as Alika was mentioning, ensure that there is a real follow-up, not just referrals, to strengthen recovery and protect physical as well as psychological health. And the best way to do that, as we've been finding, is through partnership with community-based organizations.
So, as we're getting close to the end, I wanted to shift this a little bit. Let me ask you, despite all of these challenges that we're seeing, where are you finding the hope in Maui's long-term recovery? Where are you seeing those sources of hope, of inspiration?
Again, the community. I mean, just seeing that resiliency already embedded in our community. We've been through things like this before, not as severe and not as exactly playing out like this, but we've had trauma, severe trauma in our community in the past, and it's not that long ago either. So I think learning that we can recover because we've seen it before, but also learning about some of the amazing for me, the sources of inspiration comes from some of the survivors that went through it and also are helping to create a better situation for their community around them. And I think what I'm looking forward to is seeing how strengthening that will help shape the future of Lahaina and Kula and Maui in general, to help reduce sort of this, this problem. This problem is unfortunately like an issue that I think in some ways was foreseen by certain people in our community that had awareness of the history of the place, right, the environment around them. When Captain Vancouver visited Hawaii in like the late 1700s, he described Lahaina in particular as the Venice of the Pacific. And it was lush. And because of the changes that happened after that, colonization and economic development, and the plantation revolution basically created a desert, diverted a lot of the water from that area and then changed the landscape entirely. And so I think trying to recover the understanding that the environment does shape our own health and health trajectories for the future, not only our personal, but our generational health, getting back to those practices and being able to embed sort of a healthier ecology around us as part of our recovery process is going to be really critical. So that's what I see playing out in our communities, recognizing that in different ways, and then using that information to kind of like, expand on statewide so that we can really restore health, right? And so climate change and these traumatic events happen not localized events, right? There's sort of conditions around them that exacerbate those situations where it increases the risk for these things. So similar to like what we see with chronic disease, right? There are certain situations, environmental factors that can shape those that trajectory. So understanding how to get back into a place where we can actually generate wellness early on, thinking about the ecology, about our part in the ecosystem as in the environment, I think is really critical to helping to reduce the risk for those tragedies to play out, right? And how we respond in that recovery. And so it's really identifying like the individuals that resonate with that and actually are helping to shape that out. And we've seen it in our survivors in the study, and we also see it play out with our community partners. So that's been for us really key in keeping this going.
Yeah, and like Alika, despite all the challenges, I also find hope every time I'm back to Lahaina and Wailuku as well. We are there at least once a month in these larger community events of 100 people, more or less, every weekend. But on top of that, we have the daily events, right, that our staff in Maui is handling. But, we sit with them, we review results, answer questions, and truly checking with them on how they are doing. And that stayed with us. And, one of the things that stayed in particular is their gratitude. It's that they see that this is not just a screening, but it's really the consistency of us being there. And especially this thank you coming from the immigrant populations and these mixed status families who often, feel unseen and hesitant to seek care. And simply having someone to explain results in their language and follow up matters deeply for them. So, and of course, the community organizations that are supporting them. It's really impressive what they've done. I mean, I'm really, truly grateful for them. I mean, Roots Reborn, as well as Lahaina Strong and some of the other community-based organizations. I mean, they've been amazing, right, at providing support and linking to participants in any way they can, right? So all of this, is showing us the resiliency, that exists in the community, trust, and growing this sense of collective care that we need to be able to overcome the challenges moving forward.
Mm-hmm. Well, thank you both so much. I cannot give enough appreciation to you both as far as, the work that you're personally doing, but also the work that is happening behind the scenes to, to get the funding for this study to go on. And so, thank you for spending your time, and thank you to all of you for joining us today, for showing up for Maui, for showing up for one another, and for continuing to care about the long road that comes ahead for this community. We also want to thank our series sponsors, Aloha Care, our event sponsors, UHA Health Insurance. What we heard today from Dr. Juarez and from Dr. Manakea makes one thing clear, that recovery isn't just about building structures, right? It's about rebuilding health. It's about rebuilding trust. It's about rebuilding a sense of safety that every family deserves. And the data that they shared was very powerful, but even more powerful are thinking about the people behind the numbers. The parents watching their children with breathing issues, the kupuna navigating new symptoms and systems that they haven't had to before, the workers that are trying to stay healthy while piecing their life back together, and the thousands of families who still carry the weight of the August 2023 fires every single day. So as someone who has seen the loss in my immediate family, I understand how deeply intertwined our physical and emotional health are. And these findings that our researchers shared with us today aren't just abstract with us. This is our community. These are our families, obviously. But it also reminds us of something that's equally important. We aren't powerless. We have tools, we have science, we have a community, and we have each other. And so the American Lung Association will continue to partner with UHERO, with JABSOM, with MauiWES, with local clinicians, with schools, with community leaders, to make sure that the people of Maui get the screening, the care, and the support that they need, not just today, but for as long as it takes. So if you or someone that you know needs help, whether it's respiratory screening, mental health resources, or information on clean air strategies, please reach out to us. We will stay with you. We are staying with this work, and we're staying with the community. To our presenters today, mahalo for your leadership, for your compassion, and your dedication to uncovering the truth that will help our community heal. And to everyone attending, thank you for your time, your attention, and your commitment to Maui's future. And mahalo again to our sponsors, Aloha Care and UHA Health Insurance. Let's continue to move forward together with clarity, with courage, and with aloha. Thank you, everybody.
Mahalo.
Mahalo.
Weho. Right.